history. Okay. Well, good morning, everybody. I'm going to give a short talk, just maybe 15-minute talk about dizziness.
Can you put yourself in front of the camera, please?
15 minutes on dizziness, a very important subject. Why don't you sit up over there?
Oh, okay. That's fine, very good.
And 15 minutes on dizziness, something that we deal with all the time. Is this yours?
Take that red seat, okay?
Sit there.
Perfect, okay?
I'll sit in the red seat. I put a few notes down on dizziness, but who can define dizziness for us? Can you just in a few words, what is dizziness? It's something that patients come in, you'll see them in the office, you'll see them in the emergency room. Extremely common in neurology, but also in general medicine and emergency room. Anybody dizziness?
Visual and balance disturbances.
Okay, some kind of disturbance in the environment, right? Some kind of disturbance. It could be the environment that's moving or the person themselves. It's very important to realize that most causes of dizziness are benign. When dizziness is very serious or where you have to be immediate or emergency are very few cases, but you don't want to miss those because it may be life-threatening. But most problems with dizziness is usually end up as a benign kind of common cause. What is the most important question or the most important point about evaluating a patient with dizziness? What's the single most important point that you really should know?
How long does this dizziness?
Okay, you said how long? What about you?
If it's associated with any history of falls.
Falling down. Okay, good points, but there's a very basic question and a point, and you'll see when I see a patient with dizziness. Always let the patient speak. Let the patient tell you what they mean by dizziness. And I make this point over and over again that in English we don't have many words to describe that feeling of dizziness. And so when a patient says dizziness, they may mean something else. And so in your own mind, you have to kind of identify what the patient means by the word dizziness. So it becomes very important. So the first question is, let the patient describe. And probably the takeaway today, the takeaway in the 15 minutes, is to always let the patient describe what they mean by dizziness, because frequently their description and just minimal examination can give you the diagnosis, even without a CAT scan, MRI, or any other diagnostic studies. So I think the big question is whether this is vertigo or not, right? Because if it's vertigo, it's relatively most often a benign cause. Yesterday, we saw the patient with dizziness, and it wasn't really clear what was going on, but he had the history of trauma, etc., so multiple concussions. And we came up with the possibility of superior labyrinthine problems associated with semicircular canal. So the definition is very important to let the patient describe it. The patient usually gives you the diagnosis. Vertigo. What is vertigo? The patients usually don't come in with the word vertigo. They'll come in with dizziness in English. In other languages, there may be more words to describe how they're really feeling. But in our minds as doctors, we have to think about vertigo. What is vertigo?
Sensation of spinning.
Yeah, it's a sensation. So the word you're looking for is spinning.
Yeah.
It's interesting how in English, being a doctor is so critical. So rather than jumping to conclusions, let the patient tell you what they have. It's really quite amazing. They'll tell you. But vertigo is really a sensation, right? It's a kind of a sensation of movement, or you can use the word hallucination of movement. And the other word that I look for is spinning. They'll describe spinning, either they are spinning or the environment spinning. And sometimes they describe it's more rhythmic when they turn one way or the other. And there's also a term called pseudo vertigo. So it's kind of not real vertigo, but kind of like vertigo. And you could use the word pseudo vertigo. So the main point in dizziness, in evaluating dizziness, after you get the description from the patient and let the patient speak, which is the most important takeaway, let the patient speak, is whether it's peripheral, because if it's peripheral, you don't have much to worry about, or whether it's central, right? So that's really how you want to spend your time, whether it's peripheral or whether it's central. So in terms of peripheral, what do you look for? What are the main causes?
Hearing problems.
Okay, some other symptoms, but what are the main diagnoses in peripheral?
Short span of
Dizziness.
severe vertigo attack.
Okay, like benign paroxysmal.
Yes, yeah.
Positional
Benign
vertigo,
paroxysmal.
PPP.
Positional variations, positional changes.
Okay, so we can just go through the list in your own mind. The main causes of peripheral, what we call peripheral vertigo. One is called Meniere's, right?
Yeah.
Very,
Yes,
very
Meniere's.
common, actually. What is Meniere's? Can you just give me the main points of Meniere's?
Tinnitus.
Tinnitus, right? Tinnitus, very good. Yeah.
Loss and,
Who's the second? What's the second problem? They'll have feeling dizziness. And what else?
vertigo.
They'll have vertigo. Yeah, it's a peripheral. Yeah. And the third thing that's important,
Hearing loss.
hearing loss. Yeah. So you got the three elements, right? The three elements. And the main point about Meniere's is that it's usually associated with position, right? Like, for example, it's abrupt. These are the key terms: abrupt, lasts minutes to hours, can last minutes to hours, so relatively short. It has a rotation associated with rotational component. The patient cannot stand very well because of the dizziness. They cannot stand. You can have nausea and vomiting. A fullness, there's a fullness in the ear. And then when you look at the patient, there's some jerkiness. What is that called? Jerkiness of the eye.
Nystagmus.
Yeah, nystagmus. And it's usually horizontal nystagmus. But there can be a rotatory component. And usually there's a slow phase towards where the lesion is, towards one side or the other. And the reproducibility is less consistent. So it kind of actually improves a little bit, So we're talking about peripheral. Meniere's is one. What's the second one? Benign paroxysmal positional vertigo. Just like the name, it's all in the name. Typical patient is a healthy guy or a woman. They get up in the morning and suddenly they have severe vertigo. Usually they were sleeping on one side, they get up and suddenly everything is turning and they have nausea and vomiting. A rule of thumb for me over the years is that the worse the symptoms are, in other words, very, very bad, this is a very vertigo, nausea, vomiting, sick, can't get up, doc, can't get up. Usually it's a benign. The people I worry about is the subtle dizziness, okay? Subtle dizziness. But this is after many, many years of working in medicine, 50 years in medicine. So when they describe the bad things, I sit back and say, okay, it's gonna be benign. It's the subtle, slow dizziness that lasts for a long time. that I worry about. So BPPV, paroxysmal, you got the nystagmus, the jerking. It comes with certain positions, for example, waking up in the morning, lying down, rolling over. Typically, that's the story you'll get. Bending over. Usually the vertigo lasts less than a minute. So it's a short course. And then you can do the Dix-Halpiki test and reproduce it. I don't like to do the Dix-Halpiki, shaking of the head, etc. I don't like to do it because you make them sick. So that's benign positional paroxysmal vertigo. Okay. What's another one that's kind of that's peripheral? Another one is like a viral infection, vestibular neuritis, we call it. If it's very severe infection, if it infects the whole ear, we can call it labyrinthitis. But usually it's not labyrinthitis, it's usually vestibular neuritis. And it's usually a single attack. It's a one-time single attack. No tinnitus, okay? Here are the hallmarks. No ringing in the ear, no hearing loss, and it can last for hours because it's an infection. It's an infection, and they vomit. They vomit. Okay, so that's the hallmark of this vestibular neuritis. The third one is post-traumatic vertigo, and that's the one we tend to see a lot of now because of car accidents, because of falling down, like the patient yesterday. The patient yesterday, he had multiple concussions, severe car accidents, and then another car accident, then falling down, hit by another car suddenly, and then he just suddenly fell and hit his head as well. And the vertigo, let's use the word vertigo, comes right after the trauma. So this patient almost gave us the story. Oh yeah, I have severe vertigo, pressure headache, etc. So
sensitivity to sound.
exactly. So that's another what we call peripheral. So I also toyed with the notion yesterday with this patient because he was on a number of drugs. He had bipolar disorder. He had suicidal attempt in the past, etc. Although he's very stable now. Sees a psychiatrist, all that. But he was on a lot of medication. So drug toxicity can give you dizziness. So because these are peripheral and it's bilateral. And then finally, the last thing in this vertigo, dizziness, peripheral, are the sometimes ischemia, vertebrobasilar insufficiency, stroke. Now, I want to make a point. It's very rare to have a stroke that only presents with dizziness. I would say it's 1 in 100,000. It's very rare, okay? Why is it so rare to have a patient who's having a stroke or had a stroke present only with dizziness? Why is it rare? Think about it.
Your blood supply.
The blood supply and also the neuroanatomic localization. In neurology, in the olden days, before CAT scan, before MRI, you really had to know your anatomy. You had to know neuroanatomy, you had to know neurophysiology, you had to cut the brain, understand it. The back of the brain, where the dizziness comes from, is very tight. It would be very unusual for somebody to just present with dizziness, oh, I'm dizzy, and be having a stroke. They'll have other symptoms and findings that will help you to say, yeah, this is not just dizziness. This could be a real problem. It's an emergency. For example, cerebellar hemorrhage. Some kind of vertebrobasilar ischemia or a stroke or brainstem stroke. The area in the back of the brain with the skull is so tight that you're going to have other regions involved. So if the person only has dizziness and then you examine them and there's nothing else to find, no cranial nerves, no papilledema, etc., well, it's going to be benign, good benign. Does that help? Does it help to think that way?
Yes.
Okay, so we moved from the peripheral let's move into the central. Okay. I told you when I started that when you see somebody with dizziness, the chances are that it's a peripheral problem. The chances are that it's a benign problem. The chances are that you have time to evaluate them and then make some recommendations, bring them back, et cetera, et cetera. But if it's central, it's more of a problem. Much less common, less prominent, okay? One of the hallmarks in central dizziness is that when you look at the eyes and they have nystagmus, there's no latency. It's like there all the time. No latency. And then in the central part, in the central dizziness, you're looking for other neurological findings, cranial nerve findings, etc. Also, when you look at the eyes and they're moving, and you'll see the jerking, there's no fatigue. In the first set of points that I made, the so-called peripheral, there's always fatigue. You do it many times, it gradually gets better and better and better. That's why we do the Apley maneuver. Okay. But in the central causes of dizziness, the ones that we're more concerned about, there is no fatigue. It just continues to show the nystagmus. Yes, coming.
No,
No.
you don't have to come.
Yeah. Okay. No fatigability. And the other hallmark is that when you check for the nystagmus, remember we have the optokinetic nystagmus, the tape. There is depending on how you put the patient or how you do it, there's a direction changing variability. So the nystagmus changes. Okay. And the concern we have is that this is central and this is possibly brainstem and it possibly ischemia, posterior circulation. So what are the things you look for as well? Well, you look for clumsiness, you look for the patient having long track signs, decreased vision, perhaps, double vision, diplopia. And one of the hallmarks that you always have to be aware is perioral numbness, the numbness around the lips. It always puzzled me when I was in my residency. Dr. Adams used to always emphasize that, check the periorbit, around the mouth, the numbness. Never paid much attention to it, but it kind of represents multiple cranial nerves. So it's almost it's really easy to think about dizziness because you separate peripheral from central, and then when it's central, you always look for other signs, neurological signs, and you will always find it. And ataxia, of course, if it's cerebellar, it's ataxia. So remember the anatomy, it's small in the back of the brain. There's no room for something, going back, because it's going to affect the other cranial nerve structures around it. And we have a number of patients who have CP angle tumor. What is that? Cerebropontine, yeah. So they usually present, and many of them have bone Recklinghausen's neurofibromatosis. So they present with what? They present with tinnitus, they present hearing loss, frequently hearing loss. Schwannomas, we have a number of patients with that. It affects the 8th nerve. So they have hearing loss. Some people go deaf because we can hear from 2 ears, and they don't realize that they're losing ear. 20% of them have vertigo, 20% only. So it's a posterior fossa lesion. Another condition that you think about is epilepsy. There are patients who have temporal lobe epilepsy, can present with funny dizziness. But again, it's rare. It's rare. So I always get an EEG. I get an EEG because it's, first of all, we do it here. It's cheap, it's inexpensive, it's not painful, and we get some data. So temporal lobe epilepsy, remember that because sometimes you can easily miss it. Okay. So just to kind of recap, that's it. I don't have any more. But just to recap, The dizziness is really a very easy subject. And in your mind, you have to separate peripheral, which most of the patients will have peripheral, and central, okay? And I've just reviewed the whole thing for you. Read your notes, and you'll be experts. You'll whatever you do, wherever you go, work in the emergency room or work in general medicine, etc. And you got it. Dr. Stein, that's it.
Okay, I'll stop the recording.
You know, I was going to talk about a little treatment, but our treatment is really poor, right? You know, so what do we do in treatment for dizziness, especially for the peripheral? What do? We tell patients to relax. We give them medicines to calm them down.
Maneuvers that
We give meclizine, right? Meclizine, antivert. What does that mean, antivert? It's against dizziness, right? Antivert. But all it does, it doesn't really have any major use. It's kind of a relaxant, brain relaxant. And the good news is that when it's peripheral, it usually goes away and the patient actually heals. But your main job is to separate central from peripheral. And 9 times out of 10, it's going to be peripheral. And only 1 time, it's going to be central. Is that good to kind of summarize? Pretty easy, right?
Yes, sir.
Yeah, it's easy. Well, that's what I wanted to do. So you have an idea. Dr. Stein, any questions?
No, I think it's great, great lecture.
Well, you know, it's very straightforward, very practical.
Yeah, in most patients, it's just one of those things that goes away.
Oh, yeah, absolutely. And if you know that, then you can reassure the patient. Now, you know, when they're having this, you know, this horrible, you know, movements and nausea, vomiting, and frequently they're in bed, they can't move, and you know, it looks very bad for the patient. But in your mind, you can say, well, okay, it's going to be okay. In your mind, it's going to be okay. But you have to reassure the patient. Once you reassure the patient, things get better and better and better. Okay, so we more or less covered the main theme. Always remember central versus peripheral. History, let the patient talk, not you. Physical exam, focused, face, head, eyes. So it's really easy. All right, thanks.
Thank you
Okay,
very
we'll
much.
see you the next patient.
Thank you.